Okay, brilliant. All right. Well, hello again to some of you, for those who joined in the morning. For everyone else, my name is Groen. I'm a senior lecturer in the computer science department at Brunel University, London. And I'm going to talk about local COVID-19 simulations and expansion to national. Let me see, before I start my talk, is this working? Yes. I just want to touch briefly on the tutorial this morning for those who have joined, because we went through the whole thing and then the very last command I typed in wasn't working, which was frustrating because that would have produced the result at the bottom, which gives you the mean score of the auto-validator tool. But unfortunately, the Jupyter Notebook platform was quite forgetful of the Python path. So we actually had to pass that on explicitly. This is the fix for it, which I did in the FabFleet plugin. So if you pull that plugin and you try the notebook again, it will work. But yeah, I just wanted to tell people that for those who went along this morning. I don't know what is forward or backward. I'm going to find out. In any case, I'm going to talk about our local fluent coronavirus simulator, and it's very much a collaborative effort amongst many people in our department, and almost all of them worked on it on a voluntary basis during the pandemic. But some notable names are David Bell, who was our main connecting person with the NHS Trust in London, Anastasia Anagnostou, who is the PI for the Stamina project, where we have several trials with the code, and several prominent postdocs, including Imran Mahmood and Arendam Saha. Let's see. So I feel this needs a bit of an origin story because we didn't intend to make a pandemic model, actually. My background is in various other fields, and up to this point, I was mainly focused on migration modeling, forced displacement, people escaping conflict. And when the pandemic hit, of course, I was as shocked as many of you. And my initial idea was actually to be reviewing models by other people because I have a diverse experience in simulations. And I thought, okay, I could be a good impartial voice to scrutinize other COVID models out there as someone outside of the community, but someone very familiar with building models. So that's what I started off doing initially. I did it on a personal blog, which is not very widely read, but some people picked up on my tweets, and then I put a few pieces in the conversation related to that. And I thought, well, that was going to be my role in March. Sorry, yeah, okay, I now have the forward button. But that began to change because there was actually a bit of a gap emerging, at least in my perception and in that of several others, because in March, April 2020, there was a good range of COVID models, but almost all of them operated on a national level. And for those people that managed individual hospitals or individual hospital trusts, those models were not that informative to actually make predictions about how many ICU beds they would need to reserve, or when or if they can scale back non-urgent care, and also how these direct intake numbers would change given certain factors. So what happened was that two NHS trusts in the first instance approached us, and they said, well, or actually they approached David Bell, they said, well, we sort of need a model on this, on how to forecast that. So David Bell came to me and he said, well, Derek, you did migration modeling. Do you think there's any hope of doing this kind of modeling? And well, basically during the first lockdown, we tried to put a model together. And it was very much a local collaboration. I had quite a few colleagues in the computer science department who helped me with mining assumptions, scrutinizing the model, trying to place it into context, help with input data, things like that. And I sort of did a lot of the low-level algorithmic coding, which I really love, and I hope I can do it for the rest of my life. The aim of the model was to be local, hyperlocal, subnational, like resolving individual buildings and households, to support different lockdowns and other interventions, different viral strains, and later on also to support vaccination efficacies and strategies. And the model inevitably had to be an agent-based model because that's the method that I am familiar with and that I have the most experience with. So the way we tackled that was basically, we always start with the simulation development approach, which is not just the model, but the whole end-to-end from identifying the problem you want to model all the way to either validating what you have or doing a forecast. Basically, you select situation, you obtain some data. Using that data, you construct a model. You don't train the model, but they sort of put in the rules and constraints of the agent-based model. then you may refine that given certain measures, either from the past or what you expect in the future. You then run your simulation using various tools, and then you analyze the thing either to validate whether it's anywhere near accurate or to make a forecast. Now, in the case of the flu and coronavirus simulator or FACS, we had several aspects that were quite localized. Most notably, and I think that took the most effort as well, the geospatial data is directly parsed from OpenStreetMap in many cases. So we actually extract buildings and parks and try to figure out, okay, what is the surface area of this place? And then we load that into the code. That has all sorts of drawbacks and issues, not in the least that the annotation in OpenStreetMap is not necessarily consistent, but it does give an approach that wasn't used by many other groups. And that's why we thought it would be nice to go in that direction. Also, it's quite detailed. Demographic data, because we focus on the local area, we could take local demographics from London boroughs or other places. And then also in terms of the measures, we could actually do very local measures. So if in a certain neighborhood, the compliance rate was much lower with mask wearing in supermarkets, we can actually incorporate that directly in our simulation. Very brief overview about the FACS code. So it's written in Python 3. At the moment, we mainly use it for simulations for 100,000 to 300,000 households. Every person is resolved explicitly in the code, actually, and the runtime is about, well, a couple of hours of simulation on one core. We have a parallel version, but the parallel version doesn't give the same results as the sequential one. So we're still testing it, and I'm basically debugging it when I don't have other workloads. And in terms of applications, and this is still for the sequential version, we did quite a few forecasting reports for local NHS trusts in West London. And through the Stamina project, which is an EU-funded project that runs for 2 years, it's quite large actually, it's 10 million euros, I think. We also have trials with the UK as a whole through the Health Security Agency, who's a partner in that project, and in 3 other countries, Lithuania, Turkey, and Bulgaria. And what is quite interesting is that for the UK trial, we're trying to do runs with 2 million households, and that's actually very challenging for the code, and that will require that parallel version. So I need to get going on that, really. That parallelization is in progress, but the idea is basically that every household is in a house, or perhaps multiple households are in a house. And the idea is simply to distribute the houses across the processes and to duplicate all the other locations. It's a very simple parallelization scheme. How well it performs, I don't know, but my hope is that it will scale to, say, a node for larger simulations, so that at least we can cut down the runtime by an order of magnitude, or perhaps in a good case, 2 orders of magnitude. I'll spare you the exact details, but yeah, I'm happy to share those if you're interested in that separately. Now, to give you an idea of what we're loading into FACS, this is the borough of Brent in London. So what we basically do is we extract various information from OpenStreetMap. So we look at individual hospital buildings, individual residential areas, not individual houses because they're not annotated in many places, parks, leisure, office locations, schools, supermarkets, and shopping. And for most of these location types, we directly extract the surface area of the building and we put it into the code. It's both hugely detailed and hugely simplified. It's hugely detailed because, yes, we do resolve your local supermarket. It's hugely simplified because we only resolve 1 floor. But it's very much a work in progress. And despite all these limitations, we do get quite nice results in many areas. Another thing that we have developed, especially in the last year, is to try and have a really nice, almost human readable record of public health interventions. Now, this is not really humanly readable because the font is too small and the color scheme is horrible. Apologies for that, but this is the way that it's actually in my editor. But what it basically shows is, for example, here you have the 23rd of March, 2020. For example, it will tell you like, okay, the schools are closed. So all the schools are closed except for key workers. We also closed 70% of the shops because the non-essential shops were closed. We closed all the leisure locations, so no entertainment for the people in the UK. We thought 75% of the people adhered to social distancing, 5% were wearing masks at that time, but 10% were wearing masks during shopping. Remember, in this time and era, back in the days, people didn't really care about masks yet, at least not not the masses. That's something that emerged later. And then lastly, we had 96% of the people working from home, minus the key workers again. So the idea is that we have that in a YAML file, and we as developers can look at it, but also somebody who's not that expert can at least read it and sort of give it a quick sanity check. And this is read in directly by the simulation code and applied on different days. Okay, I can spend a lot of time explaining how we model it. Basically, there are 4 steps. We have disease spread on various locations. We have disease spread within, we progress the disease to next stages. So people might be hospitalized, they might die, they might become infectious. That's the first step. Then we have a spread within the household, so people can, infect others in the household. People will be booking visits on a day to certain locations, and then we resolve infections within certain locations, like supermarkets and schools. And then at the end, we have a simple blanket equation for modeling on transport. What is quite important perhaps to convey, not all the details, I don't think I have time for that, but the main thing is we don't have R as any input parameter. What we use instead as sort of a baseline input is a rather curious metric, which is about the likelihood that an infectious person will infect a susceptible person on a 4 square meter area for 24 hours, assuming that it is indoors and not so well ventilated. We took some papers from prisons and cruise ships to try and home in on this approximate value. It's not set in stone by any means, but the value that we sort of have consensus on internally was for the original version of COVID around 7%, and then for the alpha version about 10–11%. And that is what we use as a baseline metric. That value might not be correct, but we felt it was a little bit more grounded than just using R. And that's certainly open for debate. It's just, for us, a different way to approach things. And then we have this equation to basically say, okay, this is the likelihood that a susceptible person may get infected. And it has all sorts of terms that I could explain if I had more time. Okay. Now, so we have agents, they move around. There's a probability that people get infected in certain locations. So there are a lot of sources of uncertainty. A couple of them, not all of them, but a couple of them include aleatoric uncertainty. The code is definitely non-deterministic, especially on this local area. The variability is high. It's really, really high. And if you run fewer than 10 simulations, you're going to get a very large error bar just from that uncertainty. There's uncertainty in the underlying assumptions, of course, like vaccination, efficacy, but also compliance with lockdown measures or mask wearing. And that we stratify in different scenarios, each of them with different assumptions, which is very limited. But we can't do 5 trillion runs. So you have to make painful trade-offs somewhere. And then, of course, there's uncertainty in expected future lockdown or perhaps even release interventions. And there again, what we did for all the reports for the NHS Trust was make different scenarios and be very clear about what assumptions we made. Now, there is so much uncertainty and the model itself is not super cheap. So it's really hard to cope with uncertainty. And I don't say dealing with uncertainty because that implies that we solve it. No, it's coping like, you're being attacked by uncertainty. You're trying not to just die on the spot. And it's, during the lockdown, we also had a lot of quite tight deadlines where they wanted us to try and provide a prediction. We tried to be transparent and very clear about what we could and couldn't be confident about. And then also a lot of it was voluntary effort, people doing this on top of their normal workload. And we found that there were 3 factors really important to try and do things a bit better. The first one that I think all of you can relate to is to find and adopt efficient, but also widely and easily applicable algorithms for sensitivity analysis. Because the thing is, when you're working in this regime, you can't really do an in-depth feasibility study. So you just like to have things off the shelf that you can apply relatively easily. The second thing that I'm very familiar with is just to use supercomputers to save time computing, that you're not waiting weeks or months to get a forecast, even if you have to do 1,000 or 5,000 runs. And the third one is actually the most important, but I think quite undervalued by many. And that's to try and save time and money spent on toiling researchers. Try to automate everything that people don't have to do. And I think those are the 3 directions where you can actually move the frontier on this. I think everything else is very often a trade-off on the spectrum between perfect uncertainty quantification with an oversimplified model or really bad uncertainty quantification on a hyper-realistic model. And many other efforts, I think, will just shift on that scale. And I think those three elements are essential to try and move it further. Okay, just very briefly, this is a very old result. I should have dug up an earlier one where we run the borough of Brent for an hour. So that's why you see the ensemble sort of dying at the end. And then here, a very simple piece of validation data. Not all our validations were that accurate, but we did happen to be extremely pessimistic and extremely accurate, particularly in the autumn lockdown and even more so in the January lockdown. So perhaps it was more coincidence than anything, but we got the peak in January 21, pretty much spot on when we sent our reports to the trusts, which is great. But in retrospect, there was definitely a coincidental factor to that. And the code, the code is really, really new and it needs a lot more work. But yeah, we are able to make these kind of forecasts. And this is not the total uncertainty. Don't let yourself be deluded by that. This is just, 10, 15 runs. And we just put, an error bar on that. But that's not the real uncertainty. The real uncertainty, we cannot tell at this stage. Here's some other example results. So some of the things that is nice when you resolve individual buildings is you can look at individual wards and actually look at individuals on the ward level. So you can try and identify some hotspots that map to actual physical locations. And another thing that is really nice is that we can actually look at infections by different location types. So we can see like, okay, the office, the work from home directive was effective, but the school closure was not effective, or things like that, or more mask wearing in the supermarket works well. So you have a really nice fine granularity of being able to analyze the results, even if the uncertainty of the code is still high. Okay, the last bit I have here is a little bit about sensitivity analysis. How much time do I still have? Okay, so very quickly. So yeah, basically, you can read more about it actually in the paper up above, because that's where we mentioned it. But what we did was basically a very sort of straightforward Sobel sensitivity analysis using stochastic collocation, taking a few of what we thought the more major parameters in the simulation for a single borough, run 15,000 instances of facts on the Eagle supercomputer, and use the FACMA toolkit to try and quantify the sensitivity. And this is more or less what we got. So you can basically see that at the start of the pandemic, so this starts on the 1st of March, you see that a lot of factors are at play with the initial burst of infections. And then later on, you see that a couple of parameters are really starting to dominate things. So the mild recovery period is actually reasonably important, but then the infection rate, which you can see at the top, is becoming the dominant factor. So as a summary, I have one slide after this. So the code has been partially validated, but we need to do a lot more there, a lot better. It's definitely deserves a lot of attention. We managed to make some forecasts for the general public. So there were a few articles that we made. In retrospect, the forecasts were spot on. The code wasn't necessarily entirely correct, but at least the forecast seemed to fit well. And we added a range of features and also made the whole code a bit more robust, solved bugs over the time. And our current focus is very much on scaling up and testing the parallel implementation, improving in particular the validation and the uncertainty quantification. And with that parallel version, we also want to enable province level runs and working towards a countrywide forecast. The very last thing I just wanted to say is that I'm the local chair for the International Conference on Computational Science, which is hosted at Brunel this year for the first time in the UK since 2009. So if you're interested in participating with that, there is a track chaired by Wouter Edeling on uncertainty quantification that could be interesting. And the deadline for it is the 18th of February. Thank you very much.
So do we have any questions from Jane?
Thank you. University of Warwick. I just wondered when you were looking at the model, I'm aware that Ben Cowling in Hong Kong has done for the past 10 years quite a lot of work on within household transmission and so on. Is that something you use?
I haven't actually discovered that. So my background is computer science. So I came into the literature very much from the outside. And initially, I think we're very much gravitated towards COVID-themed papers. We didn't find his work, presumably because he didn't explicitly cover COVID initially. But I am happy to learn about his papers because we are updating the rule set quite frequently, actually. Yeah.
On household models, there's also work by Thomas House. I don't know whether you've seen that. So they've been doing work looking at the ONS data, trying to resolve it to look in the UK at household, because they've got a lot of information on the households from the ONS data.
The transmission within the house.
Yeah, so like, and so they've got sort of household models that they're trying to understand about household transmission from ONS data. So you might want to look, they've got some preprints that they've just released, so you might want to.
Yeah, in the case of facts, the transmission within family or within internal households is actually really simplistic. It's just a simple equation. And I think it'd be very interesting to actually elaborate a little bit on that. So yeah, if you could share like names or links for that, that would be really useful. Thank you. Yeah.
From the or any online? No. No. Well, I guess if there's no more questions, then we'll thank our speaker again and move to a discussion session and roundup session. So I think the plan was that, I think, Peter, are you going to present a few